So it's already 7, sir. We are live with all your
Okay,
permission.
go ahead.
Start.
Your voice is not clear.
Today, sir, is
Is it a problem on my end or your end?
Sir, can you hear me now?
Yeah, now it's good.
Yeah, fine, sir. Sir, I'm starting with the introduction.
Yeah.
Yeah. And let good evening everyone present here. I welcome all the participant doctors on today's session. Let's welcome today's speaker with great honor, Dr. Kuresh B. Maskati, sir. And sir has done MBBS, MS, DOMS, FCPS, FICS, and consultant ophthalmologist at Maskati Eye Clinic, Mumbai. Today he is going to discuss on a topic management of myopia. Let me tell you overview of the topic. The skyrocketing prevalence of myopia in a recent past, it has become one of the biggest danger to eye health in the 21st century. The increasing trend to has promoted eye care professionals to adopt promising management strategies based on when and how to treat myopia, evolution of pre-myopia and myopia, personalizing myopia control therapies, etc. To learn more about the management of myopia, I would like to invite sir and hand over this session to you. Sir, over to you. Kindly proceed from here.
Thank you for us. And it's my pleasure to be with you once again. So as Faraz mentioned, we have a huge problem with myopia. There's an epidemic worsened by the COVID, and we need to know where we stand today and what are the management strategies. So traditionally, we were taught when we were doing our MBBS that there are two types of myopia. One is school myopia, which occurs when the child goes to school. And the parents asked us, why is it happening? And when we don't know anything, we use medical people hide behind the word idiopathic. So we said it's idiopathic. It happens, it's part of growing up. And the other type was high myopia. Children of 6 and 7 years of age also had very high myopia with a lot of changes in the eye, macular degenerations, cataract, glaucoma, and we used to also call it pathological myopia. And these were prone to retinal detachments and other issues. The prevalence of myopia now has been reported to be as high as 70 to 90% in some Asian adult populations. Taiwan reported a myopic prevalence of 84% amongst 16 to 18-year-olds. In India, the earlier studies in the 70s had shown only about 5% myopia amongst school children, more in the urban areas compared to the rural areas. If you look at the data from up to 2014, means much before this decade of COVID, the prevalence was roughly about 1/3 of patients in the developed countries and about 2/3 of patients in Singapore, Taiwan, South Korea was 97%. And these have only become worse. So that's why we need to to know a little bit more about myopia. Why does myopia progress? One is environment or the lifestyle, the excessive use of mobile phones, the study hours, school timings, too much of near work, number of hours of close work, less hours of outdoor activity, poor lighting, poor posture, and food habits. These are some of the things that contribute to progress of myopia. The most important new thing that we have learned in the last few years is that when we give glasses, spectacles, we give concave glasses for myopia, and we allow the rays of light to focus on the macula, the central area. Unfortunately, with the spectacles that we give, we get what is called an optical defocus. What is meant by that? If you look at the red line at the back, when the spectacle corrects the myopia so that the rays of light focus on the center of the retina and the patient sees very well, everyone is happy. But the peripheral rays of light are focusing where the red curve is. That means they're focusing behind the retina. So that is called a hyperopic defocus. So what happens is that the brain gets confused. It says that I want to focus light everywhere where the red line is. So then I need to make the eyeball grow longer. So if the eyeball grows longer, the myopia increases. So this is an undesirable part of spectacles, the hyperopic defocus. What is required is a myopic defocus. That means the rays of light focusing in the center and the peripheral rays of light also focusing within the eye. So then there is no urge or impetus for the eye to grow. So therefore, we realize now that our normal spectacles, which our children love because with that they can see the world clearly, is only part of the problem. A corrected myope, if you see the central line diagram with the concave glasses, the periphery is hyperopic defocus. That means the focusing is behind the eye. And if you undercorrect the myope is not happy. In the old days, they used to undercorrect. The reason being that there was less peripheral defocus. They didn't understand that, but they were doing something right. But the child was unhappy because the focus, myopia is not corrected. In the patient is blurred. So we need to correct myopia like in the third line diagram below, where everything is within the eyeball. So the peripheral hyperopic defocus, that's why I'm spending a little time on this, because this is not well understood even by eye surgeons, that correcting the myopia with proper spectacles still results in a hyperopic defocus in the periphery. As you can see, that the rays of light in the periphery are going outside behind the eyeball. So even in the absence of visual signals from the fovea, this stimulates myopic progression. So the brain issues a command, it issues some neurotransmitters, which makes the eyeball elongate. For every 1 millimeter that the eyeball elongates in diameter, you get a -3 correction. So why is myopia control important to us? Because an uncorrected refractive error, first of all, in many of the children in slums and in villages, they don't know they're myopic, they can't see clearly. So there is learning difficulties, reduced performance in school, the child becomes introvert, doesn't put up his hand in class, they remain withdrawn, they don't socialize well, they don't play sports, because for sports you need to see the ball at a distance or the goal post and things like that. So they remain within their books and introverts and don't do so well. The problem in India is worsened because we have so much of an overemphasis on academic performance. The child must get 10 out of 10 in his exams. Forget the outdoor activities. Whether he plays sports is not important. We don't have a good sports infrastructure. So these two things, the overemphasis on academic performance and paucity of structured indoor and outdoor activity, causes more myopia to occur. So we should rethink our myopia strategies. A beautiful study by Rose et al. In 2008 showed that children who spend less than 1.5 hours outdoors per day and more than 3 hours indoors are at highest risk of development of myopia. So therefore, we should encourage children to do low amount of near work, less than 1.5 hours, of near work and spend more time outdoors, more than 1.5 hours outdoors. So again, the same thing put in another way. The time spent outdoors, if it's low outdoor time, less than 1.5 hours, is very bad. It should be more than 2.5 hours. At least 2 hours a day they should spend outdoors. We don't know how, but the sunlight does seem to help in reducing the progress of myopia. And the Chinese tried to increase the light in the classrooms by 20 times the light. It did not help. Myopia still progressed. So it is the sunlight and not artificial light which is important. Higher amount of dopamine is secreted because of this, and this is how the myopia can be controlled. Now, what are the parental concerns? Our children will come to the eye doctor. Eye doctors don't have time. Then they will come to the family physicians, to the optometrist, and they will ask certain pertinent questions. So at this point, I just want to tell you what you should be answering. First question: Doctor, my child has got glasses. He's only 5 years old or 6 years old. Will my child's myopia progress? So there you tell them yes and no. You must make sure that the children spend least amount of time on gadgets. The smaller the gadget, the worse it is. The mobile phone is the worst. TV is better. Large TV is better. And they must spend at least 2 hours a day in outdoor activity. Then the progress chances become less. Certain amount of genetic things are there which you can't prevent. But at least this, they should eat good home food, less junk food. Then they will ask you, will my child go blind because of these thick glasses? Tell them, if you look after the eyes well and see an eye doctor once a year for a checkup, because he also checks the eye pressure, looks for cataract, looks at glaucoma, and looks at the retina, your child will never go blind. Then they ask you, can we avoid spectacles? Again, the answer is yes and no. There is a science called orthokeratology. In orthokeratology, contact lenses are given to even children who are 6 and 7 years old to wear at night. What happens? Those contact lenses press the cornea in. So they reduce the size of the eyeball. Therefore, the myopia goes down. And that effect lasts for 10 to 12 hours. So when the child wakes up in the morning, the contact lenses can be removed by the parents. And then the child can go to school without spectacles. And it's only towards late evening that the vision becomes blurred, at which point he's at home already. So orthokeratology can be done to avoid spectacles. The next question is, Doctor, I don't like, or my child doesn't like, especially if he's a teenager, doesn't want to wear spectacles. Can they wear contact lenses? This is what you call daytime wear of contact lenses, not orthokeratology. So I tell them yes and no. If your child is mature enough, it doesn't depend on the age, but if your child is mature enough, can look after himself, can follow hygiene instructions, then even at the age of 10 and 11, you can give them contact lenses to wear. There's no harm. But wearing contact lenses doesn't mean that the myopia will not progress. It's only for cosmetic reasons you can allow them to wear contact lenses. And then they're in a hurry. When can we do laser to get rid of the numbers? So we tell them that you have to wait till the age of 18 and the number should not have progressed for at least 1 year before we can think in terms of doing laser treatment. So these are some of the parental concerns which the eye surgeons don't have time. You must be able to answer these to the parent satisfaction, and they will keep coming to you. Remember, the younger the age of onset, the more the chances of progression. Now look at this on the left side of the slide. The child is 7 years old when the child has got minus number for the first time. So there is a likely increase of 0.89 diopters per year. That means almost 1 diopter per year, the child may get a myopia increase if the onset is at 7 years. But if you look at the right side of the slide, if the age of onset is late at 16 years, then the chance of increase is only 0.1 diopters per year. So that means it will take about 5 years for the number to go up by half a number. So the age of onset predicts how fast the myopia will progress to some extent. Dr. Chandrasekhar Chavan, an optometrist who's doing a lot of research work in myopia, has come out with this risk factor, where he has been kind enough to lend my name. So we put a number to this. If the child is wearing single vision glasses, it's not so good. He should be wearing special glasses, which I'll come to. If both parents are myopic, the risk is -2. If the onset of myopia is early, the risk is -3. If the child is having less than 2.5 hours outdoor activities, it is increased risk. More than 1 hour of mobile phone, increased risk, and so on. So we came out with a risk score. Just like in cancer, you have a risk score. So we called it the CQ myopia morbidity risk point system. So if the child has 3 points or less, it is low risk. If it is 6 points, medium risk. If it is more than 9 points, there is a high risk of the myopia progressing. And if it is more than 10 points, it almost guarantees irreversible damage by the age of 55 to 60, unless we institute what is called myopia control measures, which I will talk about. So to summarize, 0 to 2 risk factors are low, 3 to 4 medium risk, and 5 to 6 onwards is more risk of developing myopia. And some of the chief age factors is the age of onset, refractive error when you start, whether it is low or high, family history, ethnicity. If you're East Asian like Taiwan or Singapore or Japan, more chances of myopia, and time spent outdoors being less and time spent on near work being more. These increase your risks. So some of these risks we can mitigate. Some of them are genetic or ethnicity you can't do anything about. Why do we not like high myopia? Because high myopia, you get many of these problems: detachments, myopic retinopathy, glaucoma, cataract, and so on. So maculopathy, if your myopia is between -7 to -9, almost 126 times more chances of the macula being affected. In the picture here, you're seeing some blood clots at the macula. This is myopic maculopathy. What about retinal detachment? If your myopia is -15 and above, you're almost 90 times more likely to get retinal detachment sometime in your life as compared to someone who's not myopic. So if you see the picture below, that thin veil which is on the upper third of the picture, that's the retinal detachment. The retina is detached, you can't see the blood vessels and all that. The lower part, the optic disc is seen, and the lower part is not detached. So that's the detachment which is there. So also cataract. So -6 and above, almost 6 times more likely chances of getting a cataract early. So what are the modalities we have to control myopia? Orthokeratology I mentioned to you. You can have multifocal contact lenses, so some part corrects the myopia of the central area and some part prevents the peripheral defocus. You also get peripheral defocus spectacles, special glasses, which I'll show you, and topical atropine drops are there. Lifestyle change is important. Minimum 2.5 hours of outdoor time. Lifestyle modification, less time on mobile phones, less time on indoor activities, and healthy eating habits, less of junk food and more of home cooked food, fresh fruits and vegetables all go quite a long way in preventing the progression of the myopia. So again, telling you the difference in traditional concave lenses, which cause a light focusing behind the retina, and you have myopia control lenses, which are available now. There are 3 or 4 different manufacturers which make these myopia special lenses, which focus all the rays of light in front of the retina and therefore prevent the peripheral defocus. Then there is role of low dose atropine for myopia control. This is again something which has been recently discovered. I won't go into too many details, but atropine has an anti-muscarinic action which helps in preventing axial elongation of the globe. I told you that 1 millimeter, if the globe is longer than it should, you get a -3. So it has an effect, very low dose atropine, 0.01% atropine. And it should be used just 1 drop at night and should be used for at least 2 years before you say that it's not working, as the maximum effect appears in the 2nd year. It's not instant coffee. So which children should be offered this therapy? Kids over the age of 5 years with a documented increase of at least half a diopter. If the myopia is not increasing, there is no point. But if the child is over 5 years of age and at least a half diopter is increased in the past year or less. And if you've had a thorough discussion with the parents about this, then you should offer this. Exclude children with anisometropia, where the number is unequal in both the eyes. Astigmatism more than 1.5, because atropine doesn't help in astigmatism. Then syndromic children, what is meant by that? Children with cerebral palsy, children with other learning disabilities, retinopathy of prematurity, kids with myopia, and myopia shift seen in children who have had a pediatric cataract surgery. So these are not normal children. So you use these atropine drops only in otherwise normal, healthy children above the age of 5 years who have had a documented progression of myopia of at least half a diopter. Then what you do is you do a baseline axial length using an ultrasound and a keratometry, the curvature of the cornea, before starting the treatment. You do this even for low dose atropine as well as for those special myopic glasses, which prevent peripheral defocus, so that you can judge for yourself whether the axial length is slowing down, progress is slowing down or not. What are the barriers to use of atropine? Some ophthalmologists are still waiting for long-term statistics, especially on the Indian population, so they are not using it. I have been using it ever since it came into the market, and it really helps. Almost 60 to 70% of the patients, the progression slows down or stops completely. But when you try and explain it to parents, some parents are not convinced, especially in low myopes. When I tell them that its use may prevent the current 2 diopters becoming 3 diopters, and it may increase only to 2.5 diopters, they feel it's not such a big difference. And usually they become lazy. When they become lazy, the child becomes lazy, because every night you have to put the drop. So they put it for the first 1 month or 2 months when they buy the first bottle. And after that, they neglect to buy the bottle. And then the effect, the myopia progresses. So to summarize, it is 0.01% atropine, not 1%, which adults use. It's fairly safe for children above 5 years of age, should be continued for at least 1 to 2 years. If the myopia is stable and not progressing, you can wait and give a washout period of a year and see. If the myopia starts progressing, then you can recontinue. And you can continue till myopia stops progressing, even up to 18 years. Those studies have been done only up to 16, but there has been no serious side effects. So usually myopia in about 80% of children stops progressing up by about 18 years. So you can continue from age of 5 to even 18 years of age. So in summary, what are the options we have to put a brake on myopia progression? One is orthokeratology, which actually came in for cosmesis, but then it was found later on that wearing these special contact lenses at night can prevent the myopia from progressing. The second is low dose atropine, 0.01%, to be used 1 drop at night in each eye for several years. Then you can have multifocal soft contact lenses, not the regular soft contact lenses. And there's much interest in special lenses, glasses called myopia control spectacles. My own granddaughter is using them. There is a hole cut out in the center, which is, so that is 0 number in the center. And the periphery has got a plus 4.5. So it overcomes the hyperopic defocus. So imagine a myopic glasses with a plus number in the periphery. That is so that the rays of light focus inside the retina, in the jelly of the eye. Then it's important that you tell the parents that the child must spend a minimum 2.5 hours outdoors in sunlight. Avoid continuous close work. If they have to do school work, which requires them to use the laptop or the iPad or something, tell them to do it for half an hour, then take a break for a few minutes, and again do it for half an hour. And to blink more often when you're on the computer. And healthy foods with lots of green vegetables and fruits goes a long way. We discount diet because we feel we know too much, and we feel that diet has very little role, but it has been shown in several studies that a healthy diet and less of junk food, less of hamburgers and pizzas does help children to overcome the scourge of myopia. I thank you so much for your attention. मैं तुम्हारे पैर पकड़ता हूँ. मेरा दिमाग मत खाओ. I apologize if I have cowed your dimag, but I'll be very happy to answer any questions that you can put in the chat box. I'll stop sharing my screen now. Thank you.
Yes, thank you so much, sir. It was a really wonderful presentation. I hope that this presentation is going to help all the participants who have joined this session, sir. Sir, we have received some question from the participant, and if you allow, can I take this question with all your permission?
Please go ahead.
Yes, sir. The question is that first, please brief about photoreactive keratectomy and how it helps.
Yes, uh, that is PRK or photorefractive keratotomy is the procedure which came in before LASIK, where we shaved off portion of the cornea, very thin, just less than a human hair. We remove a little portion, so the cornea becomes a little thinner. So therefore, it bends the rays of light less, and the rays of light focus on the retina. So you can remove myopia by laser. This is a laser method, laser which is used. It's called PRK for short. It has largely been replaced by LASIK and by SMILE. These are other laser techniques. All these are to be done for children above the age of 18, where the number is stable for a year. Thank you.
Yes, sir. Thank you so much for answering it, sir. I can see there is some more question. The question is there any relationship between dietary habits with myopia complications?
Not with myopia complications, but with the progress of myopia, it is children with poor diet, less of vitamins, less of minerals, essential essentials which we get, uh, lack of protein, uh, all these cause the myopia to progress. Obesity is also a risk factor in getting the myopia to progress. So though it has no role with myopia complications, but progression is reduced if your diet is healthy. Thank you.
Thank you so much, sir, for answering it really well. Sir, I can see there is couple of questions. We will be taking last two questions for today's session. The question is, with ophthalmic instrument is used to monitor and evaluate functional changes of high myopia.
So we use a lot of equipment for this. One of the First of all, we look at the changes in the eye. We look at the cornea, the lens of the eye, whether it is clear. We look all this on a machine called the slit lamp biomicroscope. Then we use an ophthalmoscope, direct and indirect ophthalmoscope, where we can look at the retina to see whether there are any changes of myopia in the retina. And many of us have this sonography machine by which we measure the axial length of the eye, which we can every 6 months measure to see whether the axial length is increasing or not. So these are some of the equipment that we use to monitor myopes. Thank you.
Thank you once again, sir, for explaining it really well, sir. I can see there is one last question. The question is, in mild myopia, -2 to -6D, are contact lens safer than refractive surgery?
Refractive surgery is extremely safe up to almost 10 diopters. It's very safe. If a child wants to, if first of all, it can only be done when you're above 18 and your myopia has not progressed since a year. It is entirely up to the psychology of the child, of whether if they're happy with wearing contact lenses, it is equally safe. They must follow proper hygiene, wash their hands. All this the optometrist or the eye surgeon will explain. So if hygiene is well maintained, contact lenses can be worn very well, very safely for years. But if they don't want to have the hassle of daily wear of contact lenses, morning put on and evening remove, then they can undergo the laser refractive surgery to get rid of their numbers. Thank you.
Yeah, so thank you so much for answering all the questions, sir. I hope you are able to solve all the problem related to this topic of all the participants, sir. It was a really wonderful talk from your end, sir. As there is no more questions, shall we conclude this session with all your permission?
Yes, thank you so much.
Yeah. Yeah, thank you so much once again, sir, and I hope to see you again with different topics, sir. Till then, take care of yourself once again.
Thank you.
Good.
Bye-bye.
Bye, sir. Take care.
Okay.